Already, so good morning everyone. My name is Gustavo. I'm one of the head of surgery at the University of Spain. And I really want to welcome very warmly to this first to six symposium, which has been dedicated entirely to edge fibrillation and its treatment. And before we go into the nitty-gritty and the details of what this morning will look like, I kind of want to say a few words. Thank you. Really. Thank you, thank you, thank you. Thank you for being here. Thank you for finding the time to join us in this wonderful Saturday morning. And I want to say also thank you because if you are sitting here or you're following us remotely through the channel that our great partner Mandy Parks has kindly provided, it means that you've done the first step to join us in the battle against education. And we are here very passionate about it. And this is really, really a battle. It is a battle against an invisible enemy which made our life miserable. And for the majority of the people in this room, I'm sure you know what this means. You know how persistent, how never-ending this battle can be. And that is the reason why here at UC we have a dedicated multidisciplinary team of experts that really span through different specialties, going from primary care, cardiologists, neurologists, specialists in imaging, and specialists in electrophysiology and ablation and in cardiac surgery that can help you out all the way. And this is really an opportunity to meet us, to interact. And I really want to spend a few minutes to introduce you to the faculty and the team. We have Dr. Rashberg is the chief of electrophysiology section and from the cardiology department. Dr. Conway, electrophysiologist with expertise in ablation, ablation fibrillation, and also ablation fibrillation and chief arena. Dr. James Mann, specialist in pacemaker and ICD implementation. Dr. Stacy Damo, she's from the neurology department, is one of the most expert specialists in stroke. And then Dr. Tom Lower from the cardiology department, special interest in cardiac rhythm. And then, of course, myself, who will be entertaining you today and try to walk you through this journey. And really, the purpose of today is, first of all, give you a little bit of more understanding. As they say, you know your enemies. Exactly. We can really try to go to the ins and outs of what atrial fibrillation is, and I'm sure the majority of this are people in this audience know it already. But I would say most importantly, for whoever is here and is following us and knows already what atrial fibrillation is, one of let's say, the second purpose of today is to take you through by hand in the journey that we can offer here in terms of starting where the symptoms are happening and then referring to our network of primary care and then cardiologists up to the end road of treating of atrial fibrillation. Just a very quick overview of today's program. We don't have a talking about the title of atrial fibrillation, like giving you a little bit of an overview for who doesn't know it already. And then Dr. Emma will go into the insights of one of the major complications of atrial fibrillation, which is stroke. And then we will have our physiology team really discussing how we can manage atrial fibrillation. How to manage atrial fibrillation, what to do when atrial fibrillation starts to go back, when cardiovascular fails, when cardiac treatment fails. And that's when then Dr. Rashberg will be technique describing what are the capital ways that we can use the invasive way to treat atrial fibrillation, and then I will give a brief overview of what we can do from a surgical perspective and try to give a bit of more insight of the new treatments that are appearing in the horizon. And then we'll be talking with Stephanie Bird, which is our plastic coordinator for atrial fibrillation, and she will tell you every step of the way. She will tell you how to approach this. She will tell you how we can walk you through this and this journey. And then eventually we have a special guest here, one of my patients that I'm very, very, very close to, and she was kind enough to be with us to give us a little bit of her experience and point of view. Just you maintenance things, the professionals are down there. There's like what's selected the very healthy breakfast that was very good. And then bathrooms are also available. Please interact with us, interrupt us. This is just for you, and this is to be together here in the morning with this beautiful auditorium and just to chat about it. We are doing this all together, and that's what we really want to convey. You're not alone on that, okay? So before we start, probably you might put Laura here, and we're going to be without further ado, starting this recording. You ready?
All right. Good morning, everyone. Thanks so much for being here. I'm Tom Lawler. I am currently one of our chief medicine residents here at the University of Cincinnati. I'll be talking to you all about a brief overview of AFib today, kind of understanding the types of AFib. Again, I'm really excited that you're here. This is something that, to me, is something I'm very interested in. I'm actually in cardiology, and I'll be staying for the cardiology fellowship next year. So I'll probably be, seeing many of you in our clinics here and in the hospital. So really excited to kind of take that next step. AFib is also a disease that kind of hits home for me. I've had multiple family members diagnosed with this condition, and I'll talk a little bit about that later in the talk as well. But to get started, I have no disclosures, nothing to disclose. And we'll start a little bit about talking with what is atrial fibrillation. So understanding how the heart works normally and kind of what goes wrong with AFib. So we're talking about a heart health or a healthy heart rhythm. You have these electrical signals that call the upper chambers of the heart, which are called the atrials. This causes blood to flow to the lower chambers of the heart, which are known as the ventricles. And the electrical signal then travels to the ventricles, which pump the blood out to the rest of your body. So if you think about it, your heart is really like a pump. Like any other pump, it needs an electrical signal that tells it to kind of push the blood out to the rest of the body. In this model, in the healthy heart, there's one single, clean, steady electrical signal that flows to the heart, tells all the chambers to pump and sing. This is kind of the pathway of what that looks like. So it starts in your sinus node and kind of flows down through the rest of the heart. And like I said, this normal heartbeat is like a well-organized rhythm. And you can kind of think of it as like a marching band. There's one conductor, everyone is playing in sync, and there's one beat. So now we can talk about what is AFib. In AFib, you have the upper chambers of the heart, which again are called the atria, receiving hundreds of chaotic signals per minute. It's kind of just chaotic, multiple electrical signals coming from all different parts of the atria. This causes them to quiver or fibrillate, which is where atrial fibrillation receives its name, instead of squeezing in that organized way where it pumps blood down to the ventricles. And because of that, you have blood flow that becomes disorganized and can cause blood to pool. And pooled blood can form a clot, which we'll talk about later in the day as well. So the take-home point here is in AFib, there are multiple chaotic and disorganized signals kind of bouncing around the atria and causing blood flow to become disorganized as well. Again, this is kind of what that looks like. So you can see up there in the atria, in the upper chambers of the heart, there's those multiple impulses that are just kind of chaotic rather than that one clean, organized signal. So if you think about this, it's kind of like a marching band where everyone plays their own song at once. There's a lot of activity going on and there's coordination. Again, just kind of putting that to images. Over here we have the healthy heart, which you can think of as like that Ohio State marching band, right? Well coordinated, everyone steps in sync, everyone is playing in sync. It's really beautiful. It's kind of wonderful to watch if you've ever seen it in person or even on television. It's really well coordinated. And over here we have AFib, where everyone is kind of playing. There's just papers firing off everywhere. Everyone's kind of, marching to their own beat, so to say. And that's kind of what is going on in the heart with atrial fibrillation. I think it's important to touch on some of the causes of AFib because this is also what we focus on with some of the treatments. And I also think it's important to note that AFib develops gradually, often over an extended period of time. Some of the risk factors for AFib are things like high blood pressure, obesity, lack of physical activity, smoking, alcohol, diabetes, and other substance use. But I think it's also important to note that there's a strong genetic component to AFib, and men are more likely to develop it. There also can be other heart problems like heart failure or problems with heart valves, which can contribute to the development. So over time, these factors lead to changes inside of the heart itself. These are changes like scarring, stretching, especially in that atrial. These changes might not cause any symptoms initially, so you might kind of have these changes underlying in your heart, especially because it's slow and progressive. You might not notice them for a period of time. But they might not even cause any symptoms until atrial fibrillation develops. And these changes are known as remodeling and cause the electrical signals of the heart to become chaotic over time. Ultimately, the end result is going to be atrial fibrillation. Some of the symptoms are things like palpitations, so like fluttering, racing, or pounding in your chest. Shortness of breath, which is mostly like trouble breathing, especially when you're having activity. So whether you were able to climb up a flight of stairs previously, and now you notice that that's much more difficult for you to do. That's kind of what we talk about when we say shortness of breath. Fatigue, so just like unusual or unexplained tiredness, and then dizziness or chest discomfort may also be. I think it's really important to note that some people with AFib may have no symptoms at all. So your heart may be flipping in and out of this rhythm, or it may be staying in this rhythm, and you might feel like you're totally functioning like your normal self, might not notice any changes. So these are the symptoms, but not everyone experiences these symptoms. And in those people who have no symptoms, a lot of times the AFib is found by chance, whether it's on like a routine examination with the PCP or on like a routine EKG at an emergency department with the PCP. So you may be surprised to know you have AFib. You might not even notice anything, but all of a sudden someone's telling you you have this condition. Next, we'll talk about the types of atrial fibrillation. The main types are paroxysmal, persistent, long-standing, persistent. I think it's important to highlight that the three main types are the paroxysmal, persistent, and long-standing persistent. And then permanent AFib is kind of more of a decision that you make, going hand in hand with your doctor, where you're making this decision together to stop further attempts at returning the heart to normal. Again, this is a decision rather than an inherent attribute of the AFib itself. These different types are defined by how long AFib lasts and whether the heart returns to a normal rhythm on its own. So starting off, paroxysmal AFib is when episodes start and stop on their own. So this is basically when you have your heart flipping in and out of AFib in a regular rhythm on its own. Usually it resolves within, or by definition, it resolves within 7 days without treatment. However, episodes often last much longer or much shorter than this, sometimes even resolving in a matter of like hours or minutes. Symptoms can come and go along with the AFib. So like we talked about those symptoms like the palpitation, shortness of breath, maybe some chest discomfort. You might feel that intermittently when your heart is in that irregular rhythm, and then it goes away when it's back in normal. So patients can feel totally normal in between these episodes. I think really important to know with paroxysmal AFib is that just because it comes and goes or because it's not sticking around, it's not necessarily mean that it's harmless. This kind of AFib still carries a risk of blood clots forming, which can cause a stroke. And so for this reason, it's important to talk to your doctor about AFib, even if it's only infrequent and lasts only for a couple of hours. You might say, well, if my heart is going in and out of this rhythm, and it's not in this rhythm when I see my doctor, how can I tell if it is actually going in and out of AFib? And we'll talk more about that today, but there are a lot of different kinds of monitoring that we can do, whether it's with like an internal device or an external device to kind of follow your heart rate over a long period. Also important to know with paroxysmal AFib is that this usually occurs when there's less remodeling heart. So this means that treatment options typically have a higher success rate than any other types of AFib. The next type of AFib is something called persistent AFib. And in this type of AFib, episodes last greater than 7 days, and the heart does not return to a normal rhythm on its own. It needs help to get back to normal. The two options for this typically are things like medications that can revert the heart back into a normal rhythm, or electrical cardioversion, which is like a controlled electrical reset of the heart's rhythm. And important to note here that the goal in persistent AFib is to restore the heart to a normal rhythm. Next, we have long-standing persistent. And in this type of AFib, the episode is continuous and lasts for greater than 12 months. So the heart has been in an irregular rhythm for a long period of time. The electrical pathways sort of become adapted to this rhythm. At this point, the management kind of depends on the patient's goals and risk factors, because it is more difficult to restore a normal rhythm once the heart has become adapted to the changes that go along long-standing persistent AFib. Sometimes in this case, the goal of shifts control the heart rate and prevent strokes. Important to note that people with long-standing persistent AFib can absolutely live full, meaningful lives, and they're often able to maintain the same level of function. The focus on the treatment here shifts, but the goal of feeling well and staying safe remains the same. So again, why does the type of AFib matter? Stroke risk is one of the biggest things. So because the atria are quivering rather than squeezing like normal, blood can pool in the atria, and this pooled blood can form blood clots. If the clot kind of breaks off and travels to the brain, that can cause what we call a stroke. In general, the longer duration and more persistent AFib is associated with a higher risk of stroke, along with other risk factors like high blood pressure, diabetes. Those can also increase your risk of stroke. And using a scoring system, your doctor can determine if you require blood thinning medication to help prevent the stroke in this time of the It's also important for progression and reversibility. So the longer that the heart stays irregular, the more structural changes that occur in your heart. These changes are known as remodeling, like we mentioned earlier, and remodeling makes it more difficult for your heart to stay in a regular rhythm. So this is kind of like we talked about at the very beginning. You have that like stretching, that scarring, those changes in your atria. As your AFib becomes more persistent, those changes kind of continue and can actually worsen. So this is why it's important to try and catch AFib early, ideally when it's in its paroxysmal phase before a lot of these remodeling changes develop. We'll talk much more about this today. But some of the treatment options when we talk about AFib are installed rate control and rhythm control. You probably will hear your doctor say these two words. And really what this means in terms of rhythm control is restoring and maintaining a normal, regular heart rhythm. So rhythm control is trying to get your heart back into that normal, regular rhythm. This is going to be the priority for paroxysmal and for persistent AFib. So those are the kinds of AFib where your heart is either flipping in and out of it, or when it's lasting less than 12 months. We'll talk more about the tools that we can use for this today, but usually we talk about things like cardioversion, which is that electrical reset of your heart, catheter ablation, and then we also talk about anti-arrhythmic medications, which is just a fancy way of saying medications that can help keep your heart rate up regular. The other thing that we often talk about is rate control. And the goal here is to slow the heart rate to a comfortable range, even if it's staying in the irregular rhythm. So in this kind of treatment, your heart is probably still in AFib. It's probably still in that irregular rhythm, but you're trying to slow the heart rate down, essentially to where it's at a comfortable rate, and will prevent some of those remodeling changes. This is where this is primarily what we're focusing on for long-standing persistent AFib. These are medications like beta blockers or calcium channel blockers that we typically use for this. So things like metoprolol, carvedilol, those are probably some of the more common ones that you all have heard of. But that's what we're using to treat this more like the long-standing persistent AFib with greater control. The other thing that we'll talk much more about today is stroke prevention. And your doctor is going to use this score called Chad's VASC score to determine what blood pressure is right for you. There are many different blood thinner options today. I think previously there was like a very negative connotation going on with blood thinner because warfarin was our only option. This kind of required frequent lab checks, was a little bit less safe than the medications that we have today. Now we have medications that we commonly use like Eliquis or Xarelto, probably seen commercials for almost all the time, that are much safer and do not require those frequent lab checks like warfarin. So again, really helping out with the quality of life by kind of minimizing those lab checks and making it a much safer medication. Just some closing thoughts. My hope today was to give you the language and confidence to have better conversation with doctors, your families, and with each other. And I do want to share a brief anecdote as well. Like I said at the very beginning, AFib kind of hits home for me. I've had a couple family members diagnosed with AFib. One of which was my dad. So back in 2019, my dad was initially, kind of feeling unwell, wasn't really sure what was going on. This is my first year of medical school, and he happens to give me a call and says, "Hey, my Apple Watch is telling me I'm in something called AFib. What do you know about that?" And honestly, at the time, as a first year medical student, I didn't know that much about it. And when you have a family member, especially someone, my dad is like, I'm very close with him, going through some sort of medical condition certainly can be scary. So my first thought was like, oh gosh, I'm so nervous about this. What's going to happen to my dad? It's always been a role model for me. We've run marathons together. So my first thought was like, I'm scared. What's going to happen next? Through talking with his doctors, he was able to come up with a good plan. Initially, he was in that paroxysmal AFib range, so he was able to start medications to kind of keep his heart in the rhythm. And after a little while, his AFib progressed to the point where he was in kind of that persistent AFib range, where he was in it for longer than 7 days, and his heart was no longer flipping in and out of it like a normal heart rhythm would. And at that point, he again talked with his doctors, talked about the options, and said, I want to maintain a good quality of life. I want to try and get my heart back into its regular rhythm. And so really through those conversations, they ultimately decided to do a catheter ablation for him. And that was all the way back in 2021. So 5 years now, he hasn't had another episode of AFib after his catheter ablation. We still run 10 marathons together and has a very, very good quality of life. So I think that's why it's important, why I want to emphasize to you that it's really, really essential to try and push AFib early if you're able to. And also to work with your doctors and your family members to come up with the best plan. So like I said, I was very scared. I totally understand why a lot of people are scared when they first have this diagnosis. But fortunately, my dad was able to get the treatment that he needed, was able to, kind of help his heart go back to regular rhythm. So thank you everyone so much for your time today. I really appreciate the opportunity to be here. And again, like Dr. Scudace said, if you ever want to come up and talk to us, please interact with us. Fantastic.
I have a couple of questions from our online viewers.
Sure.
What is AFib and what is atrial flutter, and is it treated differently than regular AFib?
Yeah, atrial flutter, and maybe this is a question that one of our ED doctors can answer later on, but atrial flutter is a rhythm that's similar to AFib. It often has a different foci where there's like a topic piece are coming from. Some of the treatment options are similar. You can still do catheter ablation for it. You can still try different medications to control the rate, control the rhythm as well. But a lot of times, atrial fibrillation and atrial flutter can go hand in hand, and patients can actually have both of them at the same time.
Got it. One more. Does hypertension put you more at risk for AFib?
Yes. So hypertension is also called high blood pressure, and that is something that puts you at a higher risk for atrial fibrillation. Is that one still? Oh.
Yeah, I have to turn it off.
So hypertension can put you at a higher risk for AFib. And like we talked about at the very beginning, part of that is because AFib develops when you have these changes in your atria that can cause like some stretching and scarring, and uncontrolled hypertension especially can cause some of those changes in your heart that can make it more likely to go into AFib.
Is it always progressive?
Not necessarily. It's not always progressive. Sometimes people will have like a lone episode of atrial fibrillation. Especially if you have like a surgery or something like that, or you have like an acute illness. Sometimes your heart may flip into AFib while you're sick, and then you can go back into a regular rhythm and stay in normal sinus rhythm for the remainder of your life. So it's not always progressive. That's a very good question.
What about after ablation? Not like
Yeah, so a lot of people have really good success with ablation. And again, I think we'll hear a lot more about ablation later today, and kind of like an in-depth overview of that procedure. But ablation can be very successful, and like I said, my dad, has been 5 years free from kind of AFib after this ablation. So certainly those kind of procedures can be very successful and prevent it from coming out.
I guess I'm a sort of like a classic case. I didn't have any symptoms. I didn't know that I had AFib until I was on the operating table for something else. And then that's when they said we can't operate because you have AFib. However, I do have the high blood pressure. You mentioned metoprolol. Years ago, I was given that for the high blood pressure. Could that have been contributory to the AFib?
Probably not. Metoprolol is one of the medications that we use to treat AFib, but it doesn't necessarily make your heart more susceptible. So I wouldn't say that contributed to going into AFib. It's just one of the medications that we use to treat AFib. And honestly, nowadays we use a lot of different medications. We have a lot more options to treat high blood pressure. So we have better medications to treat high blood pressure. I would say that's something we use to treat, but not something that probably causes it. Yep.
Yeah, I've been taking warfarin since the 90s or something else. Does that maybe hide my AFib? Because I have AFib once in a while, once a year, once every 2 years,
So warfarin is not necessarily affecting your heart's rhythm. It's just preventing your blood from clotting. That's kind of how those blood thinning medications work. So they're not necessarily like keeping your heart in a regular rhythm or slowing your heart rate down. Really, they're just acting on the blood itself, trying to keep that thin and prevent any kind of strokes. Good question. All right. Well, thank you so much, everyone. I really appreciate it.